We're going to move on to our first patient perspective. And if we could have our willing volunteers come up and speak just a little bit. And this will be an introduction to Dr. Joel Krier's talk. And again, you're welcome to sit where you like. You know, I was thinking maybe if it was more comfortable, would you like to sit at the table here instead?
Yeah, I think we will.
How about that? How about that? Wes, Paul, do you think you could turn the microphones on there?
Okay, good morning. My name's Emma. I'm from Manchester in England. I've had aHUS and been a renal patient for 21 years. I spent 17 of those years on dialysis, CAPD, and then hemodialysis, which I performed at home. And then 4 years ago, I was lucky enough to receive a transplant, which is working really well, with eculizumab. I have the first discovered genetic mutation discovered by Professor Warwicker and Professor Goodship, factor H. And when I discovered this, or when I got kidney failure, I hadn't heard of anybody in my family that had got kidney failure. It came completely out of the blue to me. But since my own diagnosis, it's been identified that it's affected many generations. 3 of my great uncles died from aHUS, 2 cousins, and I currently have 3 cousins who are on dialysis affected by aHUS. Sorry, I've just forgotten my last little bit. When I was diagnosed, I heard the term HUS, I heard the term TTP, but I never heard of TMA until 12 years after my diagnosis. So that's my little introduction, my little history. Okay, thank you.
Hello, I'm Megan. I have had HUS for 5 years. I have currently 3 babies. You'll hear me speak along with Dr. Craig Gordon later. Mine was pregnancy-induced. We thought that we had a family history of TTP. That had been around my family for years and years and years. I've heard it all my life growing up. And so when I was first diagnosed, that was the first thing that they said, oh, well, you've got TTP because you had a grandfather that died of it, and his sister died of it, and so on and so on. And the doctors that saw me thought, no, I don't think that's it. So my kidneys had started to fail. My liver had started to fail. My platelets, my creatinine was all very low. And then my doctor said, you know what, I think that you have aHUS, because he had just happened to go to a symposium just like this shortly beforehand and knew exactly what he was talking about. 3 weeks later, I was diagnosed, and I started Soliris immediately. And TMA was around from the beginning. He gave a very long, drawn-out explanation that went over my head. TMA was not something that I understood at that point. But over time, it's become like a normal thing now to talk about. So that's my introduction.
Good morning, I'm Michael Eygenraam. I'm here from Canada. I have to apologize, I'm going to read from notes because I have details I think I should say and probably will miss if I don't, so bear with me. We're supposed to be introducing the question about when you've heard of TMA in the first place. And might be a surprise, but I was ill first in 2002 and I actually did hear the term TMA pretty well immediately by the doctors. So that's an anomaly, I think. I must have had a good doctor at the time. The Norwalk virus was going around at the time in 2002, and at the time I had developed flu-like symptoms which intensified over several days. On Christmas Eve, seems to be a problem with me, after the whites of my eyes turned yellow, my wife insisted I see our family doctor. Feeling the way I did, I was reluctant to go because I could not imagine having to sit in the waiting room for upwards of an hour. After some coaxing, I realized that I should have been improving, and not going would have worse consequences. My doctor sent me straight to our local emergent department, where I was admitted and kept overnight. Blood tests were done, and I was put on IV fluids for suspected dehydration. My platelet count was down to less than a quarter of its normal value, and my hemoglobin dropped to the point where I needed blood transfusions. I remember being completely miserable that night, cold, shivering, unable to sleep much, and left alone on an uncomfortable stretcher. The next day, which was Christmas, I had vision problems for the first time. The doctor said it could have been a TIA. Later that day, a specialist determined I had a type of TMA called TTP, and I needed emergency treatment in Toronto. Because of the lack of medical knowledge and treatment of aHUS back in 2002, all patients with my symptoms were treated with plasma exchange, regardless of assigned TMA disease. Since I was an adult and the doctors considered aHUS a childhood disease at that time, TTP was assigned. I was taken by ambulance to a cancer care center in Toronto, where I received my first plasma exchange that same day. With regular plasma exchange as an inpatient for 6 weeks, I slowly recovered from my initial episode and returned to work part-time about 4 months later. That's it.
Thank you very much, Michael, Emma, Megan. So recognize the perspective here is that it had taken some time in order to make the diagnosis. There are a number of diagnoses that were entertained. I think Emma has a unique story in the sense that what was discovered there was somewhat groundbreaking. And Dr. Joel Krier is going to tell us about some of his groundbreaking work in a similar regard. Dr. Krier is the clinical chief in the Division of Genetics at the Brigham and Women's Hospital. He's a faculty member at the Harvard Medical School. He and I have worked for the last 3 or 4 years regarding some very difficult cases. And I'll have to say, from the clinical perspective, the genetics group has been very helpful to us. I do a lot of transplant evaluation and workup, and so patients hardly ever get a biopsy, and we hardly ever know what's going on prior to transplant. And so his group has been very helpful in trying to tease out if there are any genetic anomalies that we need to be aware of prior to transplant. Joel?
All right. Thank you very much for the opportunity to be here. And I guess I have the opportunity here to share with you how I became much more familiar with atypical HUS and TMA beyond the kind of, perhaps brief mentions or encounters with it during medical school or internal medicine training. So I'm a clinical geneticist, and what that means is basically that I specialize in taking care of a kind of diverse spectrum of rare genetic or Mendelian disorders, one of which would be aHUS. And I've been participating as part of what we call a novel gene discovery initiative, which I'm going to explain a little bit. And as part of that, we have been working for many years now, 3 to 4 years, as Andrew said, with a family that we think has a kind of a variation on atypical HUS involving sort of a similar underlying pathophysiology. And I want to share that story with you today. I want to first give you a little bit of introduction to kind of explain how we came to this point, how we identified this family and this genetic variant. So until about 2011, in the clinical setting, genetics was limited to really kind of a gene-by-gene testing approach. The technology allowed us to usually look at one gene at a time, maybe a few genes. And so when we were evaluating a patient for a possible genetic condition, we would consider all the symptoms and the medical history and the family history like any other physician would in other settings, and then come up with a list of genes that we thought would be most likely to explain the presentation. We would often start, if we could get insurance approval to do so, we would start by testing the top gene on our list, and if that was negative, in some cases we might have a second gene that we were interested in looking at. If that was negative, we would often sometimes have another gene that we were curious about but may not be available for clinical sequencing, and so we would be kind of stuck at that point. However, in late 2011, the sort of clinical availability of what we call genome-wide sequencing occurred. And this allows us to look at the spelling of virtually every gene across the genome. And this changes the way that we approach genetic diagnosis dramatically. So instead of looking at one gene at a time, if this gives us the opportunity, and of course there are sometimes insurance barriers and other challenges to doing this, but it gives us the opportunity to look at up to roughly 20,000 genes with a single test, about 7,000 of which have been associated with some known human disease. So we can look, instead of looking one gene at a time, we can look at multiple genes at a time. It also gives us the opportunity to really kind of go the other direction and to see what we have found through the genomic sequencing by looking at the spelling of all the genes, and to return back to a patient or to a family to see if there is evidence that may not have been as clear to us when we first met them for a particular genetic variant that we've identified by this broad testing approach. And so we've sought to kind of make the most of this opportunity scientifically and clinically here at Brigham, and have initiated something called Brigham Genomic Medicine. This is an initiative that we started back in kind of late 2011. And the idea here was to use this new sequencing technology, to identify genetic etiologies or genetic causes of diseases that haven't yet been figured out or haven't been identified. And so we were looking for families, and continue to look for families where there's a suspected rare genetic disease, but for which the causative gene has not been found through the available clinical testing. And we use the usually kind of big families or kind of rare presentations of conditions to try and identify these previously unidentified genes. So we do DNA sequencing, usually of multiple individuals in a family. We analyze the genomic information, and then we also move towards experimental validation when we think we have a promising candidate to explain the disease. This has been a multidisciplinary effort from the beginning, involving clinicians like myself, bioinformaticians, and experimental biologists. And whenever possible, when we feel extremely confident about a gene that we've identified as being the cause of disease, we then can, in some cases, are able to really inform the management of the patient or family, and even in some cases begin to look into kind of novel therapeutics that may have not been utilized before. And so in the ideal situation, we can work with the family really through all of these steps, and essentially kind of cross over into the research space to identify a novel gene, and then when enough evidence is there to confirm a finding, kind of cross back over into the clinical world and hopefully use that information to help the family. And so this is a little bit more technical, but just to give people a sense of what we're grappling with here. So we do sequencing, which is kind of looks a little bit like this visually, and we identify hundreds of thousands or even millions of genetic variants. So in other words, points in the DNA sequence where an individual is spelled differently than what we consider to be the sort of standard or reference sequence. We all have millions of such variants in our DNA. And so the challenge is to identify which variant is the cause of a rare disease in a patient or family. So we filter the variants using various assumptions, and in particular, we look for extremely rare variants because we assume that a rare disease is going to be caused by a rare variant. And in the ideal case, we end up with a short list of genes at the end that we then begin to look at whether or not they make sense to possibly explain a particular disease. And so we then use a bunch of experimental approaches, depending upon the variant, to try and evaluate whether or not we're on to something. And this is a long process, requires identifying collaborators, as you'll hear about in our case, who are willing to work with us, and sometimes identifying another family who has the exact same genetic variant or the same gene affected and a very similar rare disease. So I want to tell you about a family and a patient who presented actually here at Brigham and Women's a number of years ago. And this is what we have called a kind of mysterious case of painful blue toes. This gentleman presented to the Brigham ER. He had recently visited his father, who was sick with pneumonia, in the hospital, and had begun to develop some fever and chills, headache, and signs of a possible upper respiratory infection himself. He had stayed home from work for a few days. He actually began to feel a little bit better by the third day, but a new symptom developed, which was severe pain in all of his toes. He had some swelling in the toes, and they had begun to turn kind of reddish, though it was changing into more of a bluish hue. He had an evidence of inflammation on his labs. His ESR was elevated. There was this question initially by his primary care doctor if this could be something related to Lyme disease, and he was actually started on a medication for Lyme. However, the pain increased and became unbearable, so he came into the ER. He was really a generally healthy gentleman, though he did have some intermittent hematuria, so you might begin to sense the connection here a little bit. And he, in the ER, did not have a fever. He was in excruciating pain, and all of his toes had this kind of dusky bluish appearance. And though he did have evidence of having pulses in the arteries near the bottom of the ankles, or by the ankles, bottom of the legs, and his sensation was intact. So this is what he looked like early on in the presentation. You can see a little bit of that kind of bluish hue here to the end of the toes, but they were exquisitely painful. There was a little bit of evidence of some possible pneumonia, respiratory infection on the chest X-ray. He actually did not have, when he first came in, had a normal evidence, or what appears to be possible normal renal function, no increase in his creatinine. And I'm not going to go into all the details here, but had evidence of significant evidence of inflammation, and did have some blood and protein on his urine. So many different types of consultants were involved in his case early on, and there was a list of different possible explanations that people were thinking about, kind of ranging from a vasculitis, a systemic vasculitis, to something called Berger's disease, which is a thromboangiitis obliterans, or some other sort of clotting phenomenon. He had an imaging done of his lower legs, imaging that looks at the MRA, which looks at the vessels, the arteries in the lower leg and feet, and he had evidence of occluded arteries down in both the right and left side. The arteries here here on one side, the dorsalis pedis, and the other lateral plantar artery. And so there was a question, though, was this caused by clotting in the vessels, or were the arteries essentially kind of spasming and causing the blood flow to stop? He had an ultrasound done of his heart, and it did not show any major abnormalities, and no clotting in the heart, thankfully. And he also had a imaging of his chest and his abdomen, which did not show any evidence of vasculitis or any aneurysm or any dissection or any clotting in the chest or abdomen. I'm just going to skip through this. And he did have at this time normal C3 and C4 functional assays. So the kind of working diagnosis after all these evaluations and being seen by many different subspecialists was some kind of unexplained or idiopathic phenomenon that was causing this coldness and lack of blood flow to his feet, possibly triggered by some infection, because he'd had this recent history of possible exposure to an infection, and also had some symptoms of possible respiratory infection. So, in addition to all that testing and all that information, someone did collect a family history, and actually got there was a genetics fellow at the time who was also an internal medicine resident, and got him involved, and he became quickly very interested in this case from a genetics perspective, because when he learned more about the family history, it turned out that there were many people in this family who'd actually had a very similar presentation. This is our patient here. It turns out his mother, and anyone here kind of with a solid black means that they actually had severe loss of blood flow to their toes, and some actually, including his mother, had required amputation of her toes. He had a cousin who had a very similar episode to his, who required amputation. And it turns out, part of the family lore was that his grandmother in the 40s was ice skating in New Hampshire and had severe pain in her toes, and they rushed her to Massachusetts General Hospital and had a toe amputation. on both feet. And so we sort of sensed here what we would call a dominant inheritance mode. In other words, for any individual who's affected, there'd be kind of a 50% chance that any of their children could be affected. However, there's what we would call in genetics terms, it's not fully penetrant. So, for example, not everyone who we would assume has a possible genetic variant had the symptoms of the cold toes. So, for example, his grandmother, I apologize, it was his great-grandmother who had the ice skating induced cold toes. His grandmother did not have a known history of this. And so for us, from a genetic standpoint, this gave us the opportunity to look for a rare genetic variant that was shared by people in the family who had the same rare symptoms or rare presentation. So in other words, we are able to do the sequencing of our patient and of his cousin. And since they only share roughly an eighth of their DNA, we are able to just focus on those shared variants, the shared part of the DNA between those two individuals, and look for rare variants that might go along with this history. And so we did genome sequencing on both the proband and his cousin. And this, when we have distantly related individuals like this, we're able to get to a reasonably short list of rare genetic variants that would change a protein. And so we would expect to find roughly 10 or so in this setting. We actually found about 7 or 8. We were able to take a few off the list after looking at them a little bit more closely. But we came up with a list of genes here, and this is, again, we're not up to this point haven't targeted a specific list of genes. We haven't looked at complement pathway genes or anything else. We were just looking at pretty much every gene in the genome for rare shared variants between these two individuals. And we quickly noticed that number 6 here would be of interest. So going into this, we thought we were hoping to find a gene that would be involved in something that was immune mediation, maybe something that we could tie to local inflammation or endothelial damage, platelet activation, perhaps a gene that would result in dysregulation of the body's clotting, or a gene that would sort of dysregulate an endothelium protein. And so number 6, C3, kind of jumped off the page here in our first review of these variants. And as many of you know here, the complement system is a very important mediator of natural and acquired immunity, and is very complicated. And this plays a central role, C3, in all 3 of those activation pathways. So now that we found this variant, we can begin to look a little bit deeper and see what it might do to the function of the protein or to the structure of the protein. And this variant, it turns out, when we began to look one layer deeper, is at an important site in the C3 protein. It's at a site where the active form of C3, C3b, is actually inactivated. And so this made us even more scientifically more interested here. And this change in amino acid is a meaningful one, and we would expect with a reasonable probability to sort of disrupt the structure here of this protein. And it's at the factor I cleavage site. And so we were able to quickly develop a little bit of a hypothesis or kind of a model for how this might work, kind of based on the idea that at the vascular endothelium, C3 would be activated, perhaps by some infectious trigger, or in perhaps some combination of temperature and infectious trigger, and that the inactivation by factor I would be blocked, and that through the downstream consequences of having an amplified complement system, or XS3B, could result in local inflammation, thrombosis, and vasospasm. There's a lot of questions that remain unanswered at this point, but this is what when we're going through this exercise of trying to identify a novel gene or a novel disease associated with the gene, this is really exactly the type of thing that we're kind of the story that we're looking for, that we can test and makes some sense. So a few other things just to note is that C3 is widely expressed. So we look at what types of cells in the body do you actually see the C3 gene turn into protein. And as you would guess, it's present in many different parts of the body, arteries, of course, and nerves and kidney. And then we also can look at what we believe to be the three-dimensional structure of the protein. And I'm not going to get into too much detail here, but to say that our mutation occurs at what we think is not only functionally an important part, but structurally kind of an interesting part of the protein, and would change the biochemistry here at the cleavage site in what we think is a meaningful way. And so now that we've identified this possible explanation, this genetic explanation, there's a lot of work that remains to be done to try and build the evidence to say that this is the cause for, in this family, these cold and toes that lack enough blood flow. And so one way to do this is to try and find other families with the variant. And then another is to begin to look experimentally to see if we can see evidence of inhibited cleavage of C3b when this variation is present. And then we also really want to begin to think about how could this potentially be used to help in the care of this family. And so it turns out that a few years, actually less than a year before we were looking into this, there had been a publication in Pediatrics, the Journal of Pediatrics, in which they reported on a few unrelated individuals that had this similar presentation, but both in their hands and their feet. And here they identified new mutations or variants in C3 in these patients. In other words, these were variants that were new in the children and not present in either of their parents. And these variants, they were not exactly the variant that we found, but they did result in a loss of regulation of C3 and resulted in loss of blood flow to the ends of the fingers. And in this case, they'd actually treated them sort of empirically with eculizumab, and had at least in one family were able to do this, one patient were able to do this, and had a dramatic response to eculizumab. And so that was very interesting to us, but still doesn't really prove our theory here because it's a different genetic variant. However, we then began to look through the literature to see if there was any other reports of this similar variant. And actually, our division chief, who plays an important role in our project, Dick Moss, had found this reference from 1993 of a family that had a variant that it's a different name here. If you're ultra detail oriented, you might pick that up, but it's a different name, but it actually is just a result of a change in the nomenclature that was used. It's actually the same variant that was described by a physician from Japan and talked about sort of hypocomplementemia actually with this variant. And so we were excited to find this, but weren't sure if this physician was practicing anymore or weren't sure how to next find the family. However, we were able to actually track down this family, and through a postdoc from Japan who works here at the Brigham, we were able to track down Dr. Koshaka. And unfortunately, it's not a clear match for our family, but there's some interesting overlap. The family has had kind of a symptom suggestive of low blood flow to the fingers, and you can see here all the individuals who had the FO2S are people who have the variant, and they all actually reported some symptoms. And one of the patients actually had frequent symptoms of viral infection, which is not something that we saw in our family. And so we then began to look at kind of within our patient, were his complement levels normal or abnormal? And this, I'm not going to go into too much detail here, but to point out that a couple of the key parts of this are C3a and C5a, as you may know. And the complement system, as many of you probably know more so than I, is a complicated system that involves both many negative feedback loops, but also the opportunity to kind of be amplified. And so the CFI here is the inhibitor that is being blocked, we believe, by our variant. And so what we saw in our patient was that he actually had a very high C3a level, and this was at baseline. We weren't able to capture him to do the specialized testing when he was symptomatic, and thankfully he's not been symptomatic again. But it showed evidence of kind of very high levels of C3a, though the function was actually within the normal range, and likewise with C5a. And so, to be frank, we at this point don't know fully how to explain these findings with our finding. We have been working with a collaborator at Washington University, John Atkinson, who is a world expert in the complement system, and have been working on functional studies actually using our variant. We had initially had some encouraging results, and follow-up results have been a little less clear. So it's ongoing work. We think there's something important to learn from this variant, but do not yet have a kind of a clear enough experimental base to make a definitive claim. In addition to that functional kind of study, we also went back to the family and began to wonder if there, in part as we involved our colleagues from nephrology, including Dr. Sidleke, we began to wonder if there was something to this connection to possible to aHUS, and given the association between C3 and aHUS. And so we were able to bring many members of this family in to see us, and they've been extremely a wonderful family to work with. We're very grateful to them. Many came to see us, and we were able to actually check for, well, first off, take a look at some of the medical records that came. And this is just one thing to kind of show you what we see here in the mother. This is a biopsy from her feet, actually, and shows a thrombotic vessel in her. This is what a normal artery looks like. And we were then able to see how this variant goes throughout the family. We found it in all of the individuals who were affected. Interestingly, but I guess not surprisingly, given what we know about aHUS, that we found it in individuals who were not affected. The people in gray here reported this kind of recurrent cold, painful toes phenomenon, but never had an episode that was as severe as the individuals here in black. But everyone who was affected had the variant, and one, a brother of our proband, who we sort of didn't think he was going to be affected based on his lack of symptoms, did turn out to have the genetic variant. We then also began to look at hematuria, because as you might remember, the one piece of medical history on this patient is that he had a history of hematuria. And it turns out that almost everyone, with one exception, who has the genetic variant also has hematuria. It's been intermittent. The patient's mother has actually been followed by nephrology here and has had hematuria, but no significant renal insufficiency or failure in the family. And so this has been a very kind of interesting patient and family to be involved with for us, and we continue to try and work and understand what's going on here more, because we think it is both hopefully relevant to this family, but also perhaps more broadly in thinking about how the complement pathway works and how TMA may work throughout different parts of the body. So we're continuing to work on functional studies, and then also kind of thinking about this question a lot of, is this some shared spectrum of disease with atypical HUS? And then we've talked a lot about what a possible role for eculizumab would be for this family. Thankfully, no one in the family has had another similar presentation. As you might have noticed, the patient's children actually have, some have hematuria. They've not been had genetic testing yet. But I think a question that we've discussed a lot is, would eculizumab be recommended in this family if, and hopefully this won't occur, but if they develop a similar presentation with severe kind of loss of blood flow to the toes. And they have been following up with nephrology, both the children and many of the adults. And a really kind of challenging question, an interesting question, is why is this thrombosis in this case isolated to the toes? And why does it not appear to, at least in a severe way or obvious way, impact the kidneys? So we've thought about, perhaps there's something related to temperature. The distal extremities can be a bit cooler than then closer to the core of the body. Perhaps there's some different kind of expression of the complement system cofactors in different parts, in different cells, in different parts of the body. But this is, I think, for us, one of the more interesting questions that we will continue to pursue. And so, in summary, we have here a family, a sort of familial disorder that's characterized by these infrequent episodes of clotting and loss of blood flow to the fingers to the toes. There's a potential, and this has been unfortunately shown in multiple members of the family, that it can advance to sort of complete necrosis, which is kind of loss of blood flow and loss of life of the tissues, and then to amputation. We've identified this variant in C3 that we believe we have good reason to suggest is going to alter the inactivation of C3b, and we've talked about with the family the possible role for eculizumab, though at this point we'd still like to obtain more evidence to prove the causality of this variant. And so I will put in a plug. And if anyone here actually knows of a family that has presented with similar symptoms, with or without kidney involvement, please do let us know. It actually can be very useful in sort of proving that the role for a gene to find a similar variant in a family that's not related to the family that we're studying. And I want to thank you and acknowledge some people, particularly Samir Chopra, who's recently finished hematology fellowship here at Farber and Brigham, and was really kind of the champion for this case and recognizing the patient family and has been involved throughout the workup. And this is our team that is involved in gene discovery. And I think in addition to anything related to this case, if you know of any families, or if you are from a family, where there's clear kind of clinical atypical HUS, and you've had genetic testing and it's been unrevealing or negative, we'd be certainly interested in chatting. Okay. Thank you very much.
Joel, thank you very much. There is a single microphone back in between the tables. We'll have a lot of question and answer sessions here now. Please feel free to pass the microphone around if you have a question that you'd like to ask. Joel, at this point, the interaction that I had was that more or less everyone involved is dormant in the sense they're not manifesting changes. I'm just waiting for the day when someone does manifest and I have to speak to an insurance company and say, I want to use eculizumab for someone who does not have hemolytic anemia and does not have uremia. but it seems like this is, again, I remember the previous time you had described this family, and Dr. Jill Escalza was talking about the idea of nosology and whether or not we really need to be redefining as to how we're speaking about these terms and as to whether or not aHUS is the appropriate term to use. In your best estimates, do you think this family has a variant of aHUS?
Yeah, I know we've gone back and forth about this quite a bit. They have not had frank renal insufficiency or renal failure. I guess I would think of them as having perhaps a very similar or even identical kind of pathophysiological mechanism that is for some reason yet to be elucidated, causing symptoms in a different part of the body. I would certainly I think close follow-up with kidney specialists is appropriate. We don't know whether or not they could have the potential to develop renal insufficiency, and then certainly they have hematuria, as we know. But I do think of it as we see this a lot not necessarily just in atypical HUS or renal disorders, but through our ability now to identify new genetic and disease associations, we see what we call phenotypic expansion all the time, where a gene that had been first identified to cause one particular clinical syndrome actually causes many different manifestations in patients, and can really kind of challenge the way that we've clinically bucketed diseases in the history of our field. So.
Hi, thanks for a very interesting talk. From the UK, and I was just interested in when you were talking about the incomplete penetrance, whether you'd looked, I'm sure in all your sequencing, at kind of other at-risk haplotypes. So, as you know, in atypical HUS, kind of factor B and factor 8 haplotypes that are kind of thought to be an at-risk haplotype for, another hit in association with, for example, with a factor H mutation. Whether there was anything like that in your family.
Yeah, so sorry, just to make sure, so you're asking, did we look at the other atypical HUS genes in this family?
So yeah, just whether, in factor B or factor H, with atypical HUS, there's haplotypes that are felt to be at risk, so kind of like a complotype, that in association with, say, a factor H mutation are thought to maybe be a second hit in the development of atypical HUS, which might explain why there's incomplete penetrance in families with atypical HUS.
Yeah, so in other words, did we find something for example, in the affected individuals that we didn't find in the unaffected? Yeah. Then that is something that we are all very interested in trying to do. It's very challenging kind of from a statistical standpoint to be able to kind of within one family, we for example, if we went hunting really deeply, we would find probably some variation in a gene in the complement pathway. But within the kind of within the structure of just this family, unfortunately, wouldn't be possible, probably not possible to prove that it was somehow impacting the risk of developing, in this case, distal ischemia, but atypical HUS. We would have picked up any other rare genetic variants, in other genes associated with this pathway. With a few technical exceptions, but we should have picked anything else up there. So, thank you.
Joel, thank you again very much. I appreciate it. So.